pediatric urologist at the Children's Hospital of Philadelphia, and he is also the director of minimally invasive surgery in the urology department there. Dr. Shukla also teaches at the Perelman School of Medicine, and he is the co-founder of the Hindu American Foundation. So, Dr. Shukla.
Thank you, Yashasvi, for that nice introduction, and thank you for this introduction, for this invitation. It's not a common one that I get, so this is an opportunity a little out of my usual wheelhouse to talk about how my faith or my spiritual tradition sort of counsels me, guides me in my path as a healer, perhaps as a patient, or when we have these opportunities. As a Hindu, you don't see a lot of chaplains in the hospital that are Hindu chaplains. You don't see specialists who are Hindus to talk to patients. While the Hindu population continues to increase here in the Philadelphia region, nationally, now there's almost 3 million Hindus by many counts, 2 to 3 million Hindus, but not too many have taken the path of chaplaincy. They're starting to now. Many universities now have chaplains, but that hasn't been a common thing. So as a Hindu, sometimes that falls upon us as physicians. When we walk into a room, we have many more Indian Hindu patients that we're seeing. And that conversation sometimes comes up, and that has helped me think about this a little bit. How do I counsel somebody in their time of suffering? What do I say to that child, to the family of the child with cancer that is terminal, that there really is no treatment anymore, that the cancer has spread? And as I think about all of those things, we know. I believe in Hinduism as a very scientifically based religion, in the sense that we don't negate healing or treatment. And in fact, the traditions are so ancient that, Ayurveda, that, the traditions of healing with, the doshas, or looking at the different qualities of a physical body. The body is the vehicle for the jiva. Jiva is a part of the soul. So it has a very important role. This body has to be preserved. The body has to be taken care of because it's fulfilling a spiritual duty. It's performing karma that's going to take that body on its path to hopefully merger with God, or salvation, or moksha, as we call it. So the body must be healed. Body should be taken care of as much as possible. So even though it's lower than the spiritual self, you have the mind, the intellect. There's the subtle body. It's called the Sukshma Swarupa, and the Sthul Swarupa, which is the body, the physical body. The more subtle planes of existence are more valued, of course. You want to identify with those because those are permanent. Those don't die. They don't get sick, but the body does get sick. And we constantly identify with the body, which is part of the problem, but that's a whole different discussion. So when the body comes out and is ill, we know that Ayurveda had found different, say, medicinal properties or plants or different practices that could improve health. Yoga comes with the whole mindset of how do we improve the physical body so that the mind can only function if the body is strong and the body is healthy. So if we're going to, move up in our spiritual existence, the body must be taken care of. And so we do yoga, hatha yoga, the physical yoga. Of course, yoga has a whole spiritual side to it, but the physical asanas are all based on strengthening this body for that spiritual journey. And breathing, pranayam, which is the deep breathing, the different ways of breathing so that the prana, or the life force, is maintained and strengthened. We have, as a surgeon, in urology, one of the pioneers of surgery, you could say, on my textbook when I was, a resident in surgery, the textbook had a picture of the nose, a person's nose being cut off and having the first real nasal graft, transfer graft from the shoulder to the nose, which was, a famous surgeon, Sushruta, who was sort of the first surgeon, you could say. Even plastic surgeons consider him the first surgeon, the pioneering surgeon, at least 3,000 to 4,000 years ago, came up with surgical techniques, instrumentation for a blocked prostate, how to get into to relieve the urinary obstruction, to all the way to plastic surgery, and many other surgical procedures were invented and sort of described even in those times. So I feel like I'm connected to an ancient surgical medical tradition. And, I don't want to go too long, but, as we think about illness, we think about suffering, yes, Hindus do consider the concept of karma, that, our lives, our current moment is based on past lives, past actions, and current actions, and they all come to the fore to this current moment. But it's more complex. It's not like, oh, you're suffering, it's your bad karma, sorry, we're going to move on. I mean, that's certainly not the view. The view for us is that as a doctor, my duty, my dharma, or my karma, I can only get positive karma if I'm doing everything I can for that patient without any expectation of reward. So, you can't be thinking about, what am I getting for this? What do I get out of this? Because then my karma, my good karma as a doctor, gets erased. Then it becomes, okay, you wanted it for money? Fine, you might get some money out of it, or you might get some prestige out of it, but you're not getting good karma. So if I, as a physician, to be on that right path, the mindset has to be, I do this without expectation of reward. And at that moment, though, our duty is to relieve the suffering to the extent that we can. We do our dharma. We tell the families that, yes, there is suffering. This is terrible. This is never a good thing. But we know that suffering is a part of being alive. And when you live, you will suffer. And how do I get you through this suffering? That is my duty as a physician, as a healer, to stand with you. You are suffering. My job is to alleviate that to the extent that I can. I'm just an instrument on this pathway. I don't change karma. I'm not God. I'm simply an instrument at this moment put in your life to do what I can. We intersected at this moment based on my karma and your karma, so I can reduce and alleviate what you're suffering. So let me leave it at that. We can get into more discussions about concepts of death and dying and all of that. And I'm looking forward to learning from everyone else on this panel. So thank you.
All right, so hi everyone, I'm Zoha. I'm the IDEA Council Representative for the Association of Muslim Medical Students, and I'm really excited to announce Dr. Chaudhary. So Dr. Chaudhary is double board certified in geriatrics and nephrology. He's also the Associate Program Director for Internal Medicine and Section Chief for Nephrology at Bayonne Medical Center. He's the Chairman of the Ethics Committee at Bayonne Medical Center, and for 2021, he was awarded the Teacher of the Year at Bayonne Medical Center by Rowan. And in addition to all these accomplishments, I just wanted to add that I personally have been really lucky to have had Dr. Chaudhary as a preceptor and a mentor, and I learned so much from him about cultural and religion and competence in these fields, from both seeing him in the classroom and also just watching the way in which he navigates patient care. So I'm really happy to have him here.
Well, thank you, Zoha. It's a real pleasure to be here and be invited. I agree with what Dr. Shukla said. This is a little bit out of my comfort zone as well. I'm used to talking about hyponatremia and osmotic, urines, and so this is a little bit different than I think most of us are used to. But it is a pleasure to be here and listen, and I'm looking forward to learning from everybody as well as the questions that get answered. So there's a lot of
Dr. Chaudhary, I think your voice isn't working, voice recording.
No?
Oh, there, yeah, we can hear now.
Okay, I'm sorry. I think it may have been my mic. I'll turn it off.
No.
But anyway, I was saying that what I first wanted to ask myself Is religion important? Well, but first, before I start, assalamu alaikum, everybody. I wanted to send peace and blessings on everybody with the traditional Muslim greeting. So I wanted to ask myself, is there a need for religion in medicine? And I think we all can agree that the answer to that is true. I looked up some studies, and it was interesting. About 80% of patients say that religion is used as a coping mechanism for themselves and during illness. And interestingly enough, 40% indicate that religion was the most important coping strategy. So I think that there's so many patients who use this as a way to alleviate some of that suffering, the crisis that they go through. And so it really behooves us to have some education and some understanding of how to approach our patients. They've done a lot of other interesting studies. They've looked at asked the general population, and about 70% stated that religious beliefs would guide their medical decision-making in critically injured people. And that's significant. I mean, I think that we talk about the information and give them data and numbers and prognosis, but their decision-making is much more complex than what we may believe to be. What they've also done is they asked about medical decision-making in cancer patients, and they gave patients a series of different decisions to make. So they rated what was most important to them. So things like, is the recommendations of the cancer doctor important? The family members, spouse, children, side effects of the medications, and faith in God. Faith in God actually was the second most important, right under the recommendations of the oncologist. But when they asked these same questions to physicians, it was considered last. So faith in God was the least important. So you can see that I think there's a disconnect there. And historically, I think that there was a huge connection between religion, medicine, and healthcare. And from very early times, antiquity, throughout the Middle Ages, and then it really changed, I think maybe since the Renaissance, since the French Revolution, where there was a separation now of medicine and religion. And really, in my opinion, I think that has not really helped in patient-centered care, because every institution we go to, they talk about patient-centered care, but oftentimes I feel it's not patient-centered care. Islam has a rich history of medicine. There's the prophetic medicine that many of the seminaries teach. There's volumes of books that are written from the early stages of Islam. We have Avicenna, we have Fakhruddin Razi, who has written on this, on how to have good character as a physician, how to approach patients, how to approach disease. And so, this is a rich tradition as well. And I think that we also have to be careful about the impact that we can have. A lot of these studies that I've mentioned, they are epidemiologic in nature. And so there is inherent flaws, I would say. So there are associations. I think it's hard to make a causation out of this. Some people believe that religion is a private matter. I think that I often approach this by a case-by-case basis. In my own experience, I've had people who have shared their religious views and their outlook on life, and I've welcomed that. I think it's important to be able to develop a relationship and a strong relationship, because they do rely on your information and your advice, and they do take that, especially if you've had a long relationship with many of the patients that we've had. I think there's also concerns for some people that there may be some coercion when you bring up religion, but I I bring it up at times when I feel that this is a way that they will be able to cope. And I find that it helps me as well, even if they're not of the same faith, because I have to cope with trauma, emotions that I have. It's saddened me immensely when I have patients that I've had for 10 years and then they pass on, and I've had a very strong relationship with them. And so, I do sometimes open up about my own faith, and then we share that. And it's very respectful. I think it helps me immensely. But I think I have some questions myself. I would like to ask, is there a place for religion in the practice of medicine? My other question is, what's the role of the physician? And does the physician add anything? I don't have an expertise even in Islam, let alone any of the other major religions or minor religions that we are exposed to. And so how would one deal with someone that is not of the same faith as I would be? So I'll stop there, and I look forward to listening to everyone and learning from them. And thank you.
Okay, CMDA, you can go next. Thank you so much, Dr. Chaudhary. That was wonderful.
Hi everyone, I'm Fiona. I'm part of the e-board for the Christian Medical and Dental Association. And I'm really honored tonight to be introducing Dr. Jerry Rick. He's the physician advisor for Rowan CMDA. He's a neonatologist and CEO of On-Site Neonatology. But more than that, he is truly a man seeking after the Lord in everything he does, not only in his own work, but in all aspects of his life. He's very encouraging to us students, and we are so blessed to have him. So without further ado, I present to you Dr. Jerry Rick. Oh, I think you're still muted.
Sorry about that. Thank you, Fiona. As Fiona mentioned, I am the owner of a neonatology practice, and we have about 70 full-time neonatologists, 17 hospitals in 7 different states over the last 26 years. And our vision statement is to optimize the physical, emotional, and spiritual health of families. And so even though we are a for-profit medical group, my Christian values do come through. And so the challenge is when we have a very multi-ethnic, multi-religion background of neonatologists, how does one bring spirituality and medicine into medicine? And I think the challenge is that I try to teach all of my physicians by example, that it's important to listen, to try to understand. No one is an expert in other people's religions. It's very hard just for your own religion. But interestingly, JCO, the Joint Commission, several years ago, surprisingly encouraged all hospitals to have physicians do a spiritual history. And you'd say, why would they do that if they're more of a professional, secular based? It just didn't make sense. But when they looked at the literature, they saw that there are hundreds of articles that show that no matter what the religion, all 5 major religions and other religions, if those patients either prayed or went to any center for worship of their God, that they had a much higher response rate synergistically with the physician's therapy. So therefore, some of the statistics that some of my other colleagues were sharing, I think, came to a culmination in that approach. Representing CMDA, my wife, Susan, who's a nurse, and myself for the last 11 years, I've been a volunteer on the faculty and also a physician liaison for CMDA. And what makes our every Tuesday night fellowship meeting for the last 11 years unique is not just the special homemade meals that my wife makes that attracts the students. If you want any physician to come to a meeting, have a very good meal, not just pizza, and they will come. And after what we've done is we've created an environment where it's typical for first and second year medical students to be anxious, to be nervous. It's stereotypical to get isolated because you're studying so much, and you have to continue putting up this facade that everything's okay, that studies are going well. And we create an environment that allows the students to come and take down that veil and say, hey, we're real, we're struggling, let's do this together. And it's not only just together with Christians. What makes our chapter unique, and there's about 300 of them spread across the United States at the majority of the medical schools, is the fact that I set the culture and the tone that we, any night that we typically have 20, 25, 30 students coming from both Rowan-SOM and Rowan-Cooper, and that's probably from a pool of about 150 students over the course of the month. But we encourage not only Christians to come, but we have anywhere from 10, 20% non-Christians who make up all of the faiths that are represented here, and even agnostic and atheist. And you say, well, why would I encourage them to come? Because I think it's important as a physician to get exposed to multiple religions, and we're better than to understand Christianity is to go to a fellowship night where we talk about what Christianity is. We have typically once a month a Christian physician from the community who comes and shares how they incorporate their spirituality with their medical practice, with their marriage, with their children. And then also the students lead after the hour-long dinner. There'll be maybe 5-10 minutes of singing songs and worshiping God. And then the students will lead a 45-minute Bible study. And just last week, Fiona led a study that was centered around our identity. And we talked about, am I a physician who happens to be a Christian, or am I a Christian who happens to be a physician? And so the concept that we have is that being a child of God, it is so important to represent God and to walk the talk, not just to go to church on Sunday or Saturday or Friday or whenever your religion does, but to make sure that you are representing compassion and sensitivity and those sorts of things. And I think one of the things that makes Christianity very unique is just the concept of forgiveness and how important that is. And it's been shown that when there's unresolved conflicts and anger, that these types of things lead to stresses, affects your immune system, affects your sleep, affects your health. And what I love about Rowan-SOM is it's an osteopathic school. I had my family practice physician growing up was Dr. Chaudhary, and he was a osteopathic family physician, and I grew up and I wanted to be just like him. When I had pneumonia in 7th grade, he would come into the room every day, put his arm around me, sit on the bed next to me, and make me feel like $1,000,000. And so I said, I want to be just like him. And so when it came to continuing to try to understand, and he would share that, it's about not only the physical, but the emotional and the spiritual, that was very unique. And so when I asked him, well, I have this opportunity for a 6-year accelerated medical school program, but I said, it's an MD program. I really want to be a DO. And he goes, no, try it. And if you don't get in, then we'll focus on getting you into osteopathy. And I also really wanted to do OMM. So I'm an unusual wannabe MD. And wannabe DO as an MD. So where does forgiveness fit in? And I think there's nothing better than talking about the theoretical, and I'll get to some other patient examples a little bit later, but in terms of my own story, everything was going completely fine for me in 7th grade, and academically in the top of the class, socially, the only 7th grader starting among the 4 8th graders. And so one day, one of my basketball friends made a joke about me, and it included the concept of homosexuality. Well, we were just learning about the birds and the bees, so he just said, wave it off. But for some reason, it really stuck. And for the next 2 years, what ended up happening was that all of my classmates bullied me, ostracized me, wouldn't pass me the basketball, wouldn't sit with me at the cafeteria. And I'm not trying to have a woe is me pity story, but in that context, my anger grew so much that finally in 9th grade, in the middle of a class, I got up and punched a fellow classmate who was teasing me, gave him a big black eye, and the bullying quit. However, the anger within me did not. And so what ended up happening was this anger continued to grow. It helped motivate me to prove myself and to be one of the 18 out of 100 in this special program to get accepted into med school early. But when I got into first year of med school, all of a sudden I found myself in a severe depression. And I couldn't understand. I was a very good Catholic. I went to church every week. I ended up being an altar boy in grade school. I was a lectern. We were reading the scriptures at Mass. All the right things that I was supposed to do. But yet I had this anger. I got depressed. And it was like my anger grew from stage 1 way back to stage 4 in medical school, where I became dysfunctional and couldn't even get up to go to class. Make a long story short, over the course of the year, I met another Catholic gentleman in my apartment building. We started doing Bible study. And I thought I understood the gospel, but what I found was that I was just doing what all the other Catholics, all the other Protestants, all the other 5 major religions were doing. And that was, I was trying to prove myself to God. I was trying to work my way to balance. If these are my sins, I'm just trying to balance them with my own good works. And everybody wants to be a good physician, a good father, a good husband, a good, whether it's a philanthropist or helping the homeless or whatever. But make a long story short is I found that what was different than all these religions, including Protestantism and Catholicism, was that Christianity was a personal relationship with God, and that all that I could do couldn't balance my sins. And I'm not going to go on to the aspects of the gospel because that's not the purpose of tonight. But once I understood that Jesus, who died on the cross, could save all of my sins, And that was what's called grace, that I didn't deserve. Then when God's Spirit entered me, then his love came out through me as a physician, as a husband. And it wasn't to prove myself to God or to anybody else. It's just simply God's love coming through me as my motivation. And so
Thank
then,
you, Dr. Hick. Sorry,
okay,
we have to move on to JOMA.
Good.
You have been wonderful. We'll
good.
get to
I'm good.
questions afterwards.
Okay.
Thank you.
Sorry. Thank you.
So JOMA.
Hi, everyone. I'm Jesse Benzel, one of the e-board members of JOMA, which is the Jewish Osteopathic Medical Association. And we are so honored tonight to be helping host Dr. David Abend, who came to RowanSOM after 24 years in private practice, which was a mix of family medicine and osteopathic manipulative treatment. He's double boarded in neuromuscular treatments and OMM and family practice. And he's currently an assistant professor in the Department of OMM. I'm sure so many people here have directly benefited from his teaching. And he also teaches and practices in addiction medicine and pain management, and is the director of osteopathic recognition at RowanSOM for the residencies of family practice, OBGYN, IM, ER, and psychiatry. There is a Jewish proverb that to save a single life is as if to save the entire world. And by that measure, Dr. Abend has saved the world several times over. I will give him the microphone. And I also just want to thank Rev and the entire IDEA Council for putting together this very beautiful and meaningful and important event. Dr. Abend, the floor is yours.
Thanks. Wow. Jesse, remind me someday to use you as a Toastmaster. It's pretty cool, man. Listen, first of all, I'm really honored to be sitting amongst these three esteemed gentlemen with me. I've listened to all three of you, and it's really great that I didn't have anything prepared whatsoever. So it's great that I'm the fourth one, and listening to the other three doctors, now I've got some material. First, I want to say to Dr. Rick, I did meet you several years ago. You're an incredible human being, but I am going to forgive you for not becoming a DO. So I appreciate being the lone DO on this broadcast. It's pretty cool. So thank you. And Dr. Shukla brought up some interesting thing. I don't know if you've all seen it. It's probably the best medical show no one's ever seen is The Nick. Has anybody seen that? Oh, you have to. It's a 2-season, started on Cinemax. It's actually loosely based on the story of William Halstead, who was addicted. He's a surgeon addicted to cocaine. And so anyway, I'm not going to spoil it. It's a phenomenal, probably the best medical show ever. Anyway, you mentioned that surgery with the grafting. There's a scene in that movie, in that show in the beginning where I don't know if you saw this, but that was actually a treatment for syphilis way back. And in this, you brought that up. It was wild because one of his girlfriends got syphilis, and she was beautiful, and she was losing her nasal structure, and they had to actually graft her arm to her nose. And it really just brought that picture back immediately. So thank you for that. And Dr. Shukla, it's interesting, brought up a lot of what is really the basis of osteopathic medicine. So much of what I do, and I've been blessed in family medicine to have taken care of a diverse population of every faith, gender, etc. in my lifetime. And so it's a big blend. And I grew up in a conservative Jewish family. My father is actually from Williamsburg, Brooklyn, where the center of Orthodoxy. He was brought up Orthodox and later more conservative Judaism. And I'm probably more secular, they say. I prayed with my patients. I've accepted all of the different types of religion, diversity around. It's really just been a part of my life. The fact that I do osteopathic manipulative medicine. I've never stopped using my hands since I left medical school in Missouri, in Kirksville, when it all started. Puts me in a very different category because I need to develop rapport. And many of the students on here who have been in my office or will be with me will notice that one of the most important things is to sit down eye to eye, establish eye contact, and develop a relationship and rapport, which is probably the most important thing, especially if you're going to be not a one and done type of physician, but someone needs to feel comfortable with you. And then I go one step further, using my hands as an additional tool. Many times in medicine, I have to break through a barrier, an invisible barrier that people have. And so this has to transcend a lot of different beliefs and religions and things. So I've been able to do that in my career. But first, you have to be a human being and you have to appreciate that. So that comes with experience. I think all four of us on this panel have experience, and that's key to teaching these students that. As far as religion and medicine, I've had the good fortune of meeting so many students and doctors of different backgrounds that it's just a natural outgrowth of primary care and then using my hands. You know, Dr. Still, Andrew Taylor Still, who is an American icon from Virginia, who started osteopathic medicine, was actually a surgeon in the Union Army and was an abolitionist. I'm a big proponent of history. Most people don't know the history, and I teach it all of the residencies. And if we don't know where we came from, you're missing out, because it's a rich tradition in America. And it's funny because I've had exposure to acupuncture, homeopathy, all these Ayurvedic, et cetera, because many of my patients came from India, Pakistan, et cetera, and would ask me, listen, is it okay? Are you okay with us using homeopathic remedies instead of traditional remedies? And I'm saying, sure, no problem. I've heard of that. Not a problem. And I acquiesced to that. And it's been a really nice journey. I took yoga a few years ago with one of our students who brought it in from Lifetime, where she was an instructor. Beautiful stuff. So a lot of this mind body is coming all the way back. And one of the things, you know, Jesse mentioned one of the residencies that I have to teach and inculcate osteopathic manipulative medicine into is psychiatry. And some of you might be like, how does that work? Because Freud is like, hands off, no way. Psychopharmacology started in the 50s. So before then, they just threw people away and called them insane and isolated them in society, like the pandemic we just went through. And I lecture every year to the psychiatry department that the origin of osteopathic psychiatry was to reinvigorate people and get them back into a social atmosphere. And Dr. Still actually taught osteopathic physicians and osteopathic psychiatrists to use their hands in addition to bringing people back into a socialized atmosphere. They didn't have medication at that time. You know, that was back at the end of the Civil War in the early 1900s. Which was a very barbaric time in medicine, and a learning opportunity for many doctors. And he sought to improve upon it by adding the use of hands-on osteopathy, or it's a very archaic term. Now it's called osteopathic manipulation, and bringing that into medicine to use to help the body heal itself. Because as Dr. Shukla mentioned, the body has an innate desire to heal itself. And if we as physicians can assist that, it's a really beautiful thing. And if the patient needs surgery, if the patient needs medicine, et cetera, we also have that complete training to offer that as an option. And that's what I've been so blessed to add. As far as religion is concerned, I couldn't be happier to be talking to all of you in this kind of panel, because in family medicine, if I did not accept all of the religions and the diversity that I had in my lifetime, I wouldn't be able to practice. So I've been blessed literally to have met people from all different faiths and share that with them as I do now. I'm going to stop and let this keep going. So I hope, Jesse, I didn't have any prepared. I'm really good at talking off the cuff. I hope that was good enough.
Thank you so much to all our speakers for giving some of their background as it relates to their specific religion. Right now, we're going to go into some of the questions that were submitted from students before this panel. So, first question, how can we better provide end-of-life care for individuals and their families / caretakers who find comfort in religion? So if any of the panelists want to take that question first.
I'm going to go first because I know everybody else is going to say something more prophetic than I am, but I will tell you that I've had the opportunity to do hospice at home, and early on, I stopped practicing inpatient medicine about 5 years into practice, and house calls too. But I will tell you that my osteopathic training makes me unafraid to touch people therapeutically, and simply sitting down, making eye contact, holding their hand, crying, emotion, etc. It's a beautiful thing. We've lost that. I don't mind. Actually, I had an experience about 3 weeks ago in my practice where I took a chance. I know where we are right now. It's a little different, but a woman broke down in my office who had a PTSD history, and innately I just put my arm around her and consoled her. She cried, and I got a phenomenal note about a week later, and she was a devout Christian, and wrote me a beautiful note of thank you that she had not let people into her life like that. And I took a shot, but that's part of my family practice training. We just emote with people and share that. I think that's a good thing, and I would do it again if I had to. It's a risk, I know, but that's just part of my personality, and I think that that's important, that we need to show our true nature as people, as human beings, first and foremost.
Yeah, I'd like to add, I think that in my practice, especially with the geriatrics that I do, the great thing for me is that I have a relationship with a lot of my patients from before. And I think having that strong relationship really allows for you to have those conversations early. And the earlier, the better. I think often we think hospice is when they're actively dying. There's really no benefit of hospice at that point. It really should be earlier. And many people say that it should be when the medical condition is diagnosed. So that way there's time, and it could be 2 or 3 years from the initial diagnosis of the cancer or the other medical issue that they have. So that way there's time. So for example, I have a patient that came in a few months ago, has a brain tumor, and he said, I don't want anything done. I've discussed it. He's fully ambulatory, no medical problems. And he said, I just want to enjoy the time that I have, and what can I do to maximize that? And so we came up with ideas of what will happen. And when the time comes, we will get him in hospice, and we will allow the process to go peacefully. So I think the take-home message for me would be to really start them early, not even when there's 6 months left. And now there are clinics actually that are starting that have palliative care as outpatients. And you go and you discuss this and have discussions about palliation and about symptom relief, even before anything major happens.
Yeah, I really appreciate what both of you have said. And, to me, in the pediatric world, dying is very raw. The parents are there with the child. They're going through a process, and I know Jerry knows this much more than I do, of course. But when I've sat with them, it's really to give them that respect of being at the vigil. Sitting with them during that time, that you are available. I am here. If when I offer them, what can we get you? What can I do at this moment that would be of some help to you or solace to you? Certainly, we offer a chaplain based on and if they are of the faith and they would like that. Many people don't. This is just not the time. I cannot process this. just please let us be with our child. And others welcome it. And making sure that those resources are available to them is critical. Being really mindful of that spiritual side of that suffering. And if it's a Hindu patient, someone that I can help with, then there's a different conversation that there are certain prayers that we do to ease that transition, to separate the soul from the worldly, from that body, and to give it so that it's what we call liberation or moksha, to move that process along. There are certain prayers that might be said. Those are, it's really being human at that point. This isn't the time to preach. This isn't the time to impose. This isn't the time, let me tell you about my faith or what I think about your suffering. But it's really having that conversation to say, I am here in this moment, and whatever you might need, I am here to provide that. So I think that compassion, that love, that I might have, I mean, it just comes to my mind. I operated on this child with a bladder tumor. Right after the surgery, weirdly, sometimes surgery, just the stress of surgery caused that tumor to just blossom and metastatic spread. I mean, we got the tumor out of the bladder. 3 months later, it was everywhere, in the liver, in the spine. It had metastasized terribly. They sort of looked at me, that feeling of how, there was nothing on the CT scan, on the MRI 3 months ago. You do this operation, you tell me everything went well, and here we are, and our child is going to leave us now. And at that point, it's absorbing that, but being there, not shrinking away from the room. We did everything that we felt we could do, and they're not looking to blame, but they also know if you're shirking, and just being in their presence and showing them that you feel the sadness that they're going through. You can't be immune to that. That you were so invested in that child's care. This was the outcome nobody wanted, nobody expected, but I'm here to to sit with you and in vigil over that. So, I mean, I think that's the best we can do in those times, and offer that spiritual care if they seek it, but really against imposition or let me tell you about how, or what will save you. No, I mean, I think that's really important to me, is to say, if you ask, I offer, but otherwise I'm here.
I also, before Dr. Rick goes, I just want to say real quickly, I don't know about the other three physicians, I'm sure you have. I've actually gone to some of my patients' funerals, in addition to praying at the bedside and being there. I'm not afraid to do that. A lot of people feel that you might feel detached. I disagree with that. I think it's a wonderful thing, and people are really, really appreciative. That's happened to me before.
About 6 years ago, one of my Hindu neonatologists was in a major car accident where she ended up in the ICU up in Rochester, New York, and her two children were injured. Her husband was injured, and her father-in-law and mother-in-law were there. Her mother-in-law got killed in the accident. The father-in-law did not know that it occurred. They kept it from him. As soon as I heard Friday afternoon, I drove straight up there and went to her bedside and asked her, my neonatologist, what can I do to help you? And she said, first is play what I would do, be the doctor, find out all the information, make sure everybody's getting all the proper care. But then she said, what are we going to do with how we're going to share with my father-in-law about my mother-in-law passing? And so I said, you know what? I know you're Hindu, but let me see if they just, for some odd chance, as you said, there's not very many Hindu chaplains. And lo and behold, 5 minutes away from the hospital lived a Hindu chaplain for that hospital who came in immediately and even spoke that unique, unusual dialect that the father-in-law knew, and he helped minister to that father-in-law. So it's an issue of sensitivity, individualizing every situation. When it comes to neonatology, the key thing is good communication from the very first time you meet the parents, and being honest, transparent, and communicating well. And if the child, the baby is, or the preemie is doing poorly, it's important to give them an objective view of what's going on, but never to kill the hope of the parents unless you really see that things are going south. And when that occurs, they appreciate much better for you to be truthful and upfront so they can prepare themselves emotionally and to, to help them. And just the very last case I remember that I was involved with, a baby doing very poorly. I was down in Savannah, Georgia, Candler Hospital, and initially I thought this baby had group B strep. We immediately put on Amgen. Then we switched over to thinking that there's an inborn error of metabolism when there started being pulmonary bleeding coming up the ET tube, and it turned out being an inborn error of metabolism. But the point was that out in the waiting room in the South, the Baptists were very strong in this Black African-American family. There's about 5 of them out there, the great-grandmother, the grandmother, the father, the mother, and siblings. And as I was sharing with them that I really didn't think this baby was going to make it, I says, but what we need to do is we need to pray, because I could tell that they were already in the corner praying. So I says, can I join with you and pray alongside? And it just brought trust and unity and encouragement. And there is a place for suffering. And I'll just read one verse in Romans where it says, we also glory in our sufferings, because we know that suffering produces perseverance, perseverance, character, and character, hope. And hope does not put us to shame, because God's love has been poured out into our hearts through the Holy Spirit who has been given to us. So it's a very complicated thing. And when I was a first-year medical student, I didn't understand why babies suffered. But I don't believe the scriptures give all the answers. God is a supreme being. We don't understand everything. But I think through the years and through the scriptures, I've been able to console and give parents hope, both for their babies to make it or when they don't.
Thank you so much to our speakers for answering that question. That was a very deep question, and I'm sure it was, I've received some responses saying that it was emotional to be listening to this. So yeah, thank you so much for sharing that with us. Our next question would be, how do you handle a patient who may be hesitant about trying a life-saving treatment because of their religious beliefs?
Okay, I'm going to start this. I wanted to jump in after Dr. Rick brought up that, but one of the religions that's not represented here totally is Buddhism. And one of my patients, who happened to be my student, who then became a colleague, the father was Christian and the mother was Buddhist. Father passed, and he went in the hospital and slipped into a coma, from a hepatic coma, and through the weekend. And many of you in medicine will go in and do night call, etc. And this was when I was doing inpatient medicine. And he reached his 40th birthday. His mother came in, it was a Saturday night, and I had to actually call administration to get permission for 2 Buddhist monks to come up from South Jersey, because the mother insisted that no one come into the room, and he had a Buddhist ceremony which would take about 24 to 48 hours. And I acquiesced to that request, and I demanded that they meet that request, which is unusual. But I got the nursing supervisor. By the way, that's a hint for all of you medical students. If you don't know what to do, call the nursing supervisor. They're amazing. I don't think that's changed ever in hundreds of years. They made it happen. Administration, finally, they were actually on call, and you had to wake up somebody administration to approve that. And they had a Buddhist ceremony for the entire weekend, which was very nice. Also, as a third-year medical student, I got to watch. I don't know if any of you have seen this because we're kind of near Lancaster, Pennsylvania, but I was in South Bend, Indiana, and Napanee, which is about an hour away, had a big Amish population. So I don't know if any of you have had experience watching an Amish birth or when Amish people are in the hospital. It is absolutely fascinating. And it's a very stoic and serene experience. But many of us have had these experiences, and you need to be open to all of this. And if you're the physician in charge, if you're on call, if you're the one that makes a decision, and you need to be open to everything. And that's part of the psychosocial, emotional Venn diagram that we need to keep in our minds. So I forgot the question, Ravati. I'm sorry. Was there a question I had to answer? I just want to throw that out there. So.
Yeah, so the question was, how do you approach patients that may be hesitant about life-saving treatments because of their religious beliefs?
Sorry, I went off the grid on that one. It's really their decision, and it really depends legally if they have a living will. There's a lot of legality here. If they're competent to decide and not incompetent as per a psychiatrist, then it's really up to the family, and I give them, I think I try to give them that respect, because listen, all of us are going to be in this situation one day. If you haven't already, I've been there several times. So I've been through this myself with my family and my loved ones. So I think that comes from experience. It's really a respect that you have to have for the family. I'll let everybody answer that.
I think, my role is really to give options to patients. And I think that the values that I have may not be shared with the values that they have. What brings to mind is, what Foucault says about the medical gaze and how, we look at patients as these organs and these diseases. We modify the patient's story fitting into this biomedical paradigm that we have, and filtering out the non-biomedical material information. And I think we need to be more holistic and understand the thinking process. And what is the reason that they have decided to choose this option rather than some of the other options? And it may be a legitimate reason, or it may be some misinformation or miscommunication that they may have. And so I think that we just have to understand their perspective and literally try to put ourselves in their shoes, because there's all kinds of reasons that people are making decisions, whether it's related to finances, whether it's related to suffering or alleviating suffering, or some kind of atonement. And so people are complex, even within our own denominations and our own religious values. There's culture, there's class, there's race. There's so many, social factors that go into decisions, that just giving someone options and even thinking that it's an easy choice. I think that we undervalue the complexity that's involved in making a decision, especially a life-threatening condition that they may have that requires, a decision quickly.
Yeah, I agree with Dr. Chaudhary very much there. We in pediatrics, we're a little bit protected by the law. So, a family doesn't have the right to really stop a life-saving treatment if it's available, to say, no, we're just not going to do that. We're going to let them die. But things aren't always so black and white, right? I mean, there are certain treatments that it may help, but there isn't enough data to say that this is definitively the treatment that's going to work. And so it's a lot of compassion, it's a lot of understanding, it's building trust. Hopefully you're not walking into a situation where you have to make a life and death decision, you've never met them before. In those cases, certainly science takes over. I mean, if a Jehovah's Witness patient has a son who's getting, was in a traumatic injury and we're going to have to do surgery, we can't ask about the blood loss. The blood is going to be given. Really is in that sort of life-saving situation, for example. That's just to take one example. But typically, you're going to have a big discussion. What could we do? What are things that we will do to ensure that hopefully blood doesn't have to be given? We'll do everything we can, but if it's necessary, will be given. These types of discussions are had. For me, what I have seen more is not the families that don't want the life-saving treatment given. But it's more, and again, Dr. Rick probably knows much more about this, is the patients families that want to prolong the care of their child, who has no hope for reversal of the condition they're in, wanting to, not cease any type of intervention, to continue intubation, to continue the ventilator until, even though there might be brain death, no, there's a chance that a child can come back. Those are the more difficult conversations. Those are the ones that really take a lot of compassion, a lot of patience. You don't always have a living will in a situation like this, and families need to work through their grief and their trauma. And we don't push the envelope in those. We have conversations, and sometimes faith comes into those conversations, and what this might mean that, for a Hindu family, do you want to continue, we're tethering that spirit to this body that is not going to be of use anymore. The spiritual journey has stopped. We're becoming an impediment to this progression of this soul towards moksha. And really the right thing is to let that soul continue its journey, and that we should, let that journey begin. So these are the types of conversations you might have, but again, that's not something I'm going to walk in on rounds and just lay on the family. You have to have that trust, and that's where NICU doctors and PICU doctors like Dr. Rick have much more of a relationship. They're seeing those families every day. But for us, for the most part, if it's a life-saving treatment, that child needs to get that treatment.
I think the key is to try to understand the patient, and asking questions and really listening, and also asking them what their understanding is of their religious beliefs. If there happens to be a clergy that they can refer you to that may help as a consultant, those are helpful too. Interestingly, when I almost got a new hospital contract about 8 years ago in the UAE in Al Ain at Oasis Hospital, one of the things I found out about their local culture in the neonatal intensive care unit there throughout the UAE is that the biggest challenge was that they, even when babies appeared to have no signs of, hope and, brain activity, and EEGs were just dismal, that their culture would not allow them to extubate. And I'm really not sure whether this was related to, the Muslim faith, or whether it's just culture locally, but that was a major challenge had we gotten that contract that was very difficult for all neonatologists in the UAE. Then when I'm thinking of, Dr. Abend mentioned the Amish. We have a hospital in Ephrata, Pennsylvania, which is Amish and Mennonite company. And I remember I got called to the delivery room to do a consult on a 20-year-old newly married Amish couple who she was in preterm labor. She was somewhere between 22 and 23 weeks gestation. And this was probably 8 years ago, 10 years ago. And in that context, even though morbidity and mortality have improved since then, back then it was really very minimal chance of survival, let alone without any morbidity. So when they asked me, what did I recommend, because they could not stop the preterm labor, I says, well, what do you guys want to do? And they says, well, and I was shocked because they seemed like a young couple, and they were very mature. And they simply said that it doesn't sound good. And we believe, and these are their words, the sovereignty of God. And there's, a passage where in Job says, naked into the world we came, naked we will depart. The Lord gave, and the Lord has taken away. May the name of the Lord be praised. And they were very familiar with that concept. And they said, we don't believe that God is, letting this baby go to full term. We're okay with not doing nothing. And so I didn't even need to consult. But they said, no, by the way, what would you do? And I said, I'm in agreement. And majority of parents are very scared and they just want our advice. But I think it just shows you it's important to communicate and to ask their understanding, their background. And the other place was in Lakewood. We had a hospital in Kimball Medical Center for several years, and also in Community Medical Center, where the Hasidic Jewish population is very prominent. And I absolutely loved working there for the few years that I personally was in the hospitals. And the reason is they taught me so much about the foundation of Christianity through the Jewish religion. And they taught me so much about their culture. And so it's very important, it's not only end of life, but just how to get inside their minds and become one of them in order to give the best patient care.
Thank you for those responses. Next question I got from an attendee. They say, I am an atheist. In the past, I have been asked by patients and patients' family members to pray with them. This makes me feel uncomfortable. Sorry, give me a second. This makes me feel uncomfortable, but I do not want to complicate these sensitive situations by refusing such a request. How do I navigate a situation like this without compromising my own beliefs and still contribute to my patient's spiritual healing?
I'll take that. I think as a physician, we're often called upon to go out of our comfort zone. That's something we're signing up for when we do this. So, as a Hindu, I've been asked many times by a Christian family to pray with them. I will, happily, stand, hold hands, put my head down before surgery. They want, before I take their child back, will you pray with us? I will pray. I've had, I've done complex sort of hypospadias repair for a Jewish child, and right afterwards, the moil's there, and we, they have a ceremony, and they ask me to join. I'm happily going to join, and do what might be asked of me as a physician. So I know that it may not be what I believe, or it may not be exactly, but if it doesn't, I can't lead a prayer for them, or, I'm not going to say, let me take you through your spiritual journey. But I can be a participant. I can be there because I know that this will bring them great comfort as I take their child back to surgery. Then I have been very willing to do that. Now, that's a comfort zone. Now, if you completely goes against every belief that you have, I suppose you can, very nicely explain that, that I'm not the best person for that, or it's not something that I commonly do, but I'd be very happy to call, our chaplain or the right person to do that, to stand with you in prayer. So, but I think it's a little imposition on us. It doesn't take much of us, but our being there is very meaningful to them. So I've had a low threshold, and I found that it brings great meaning and comfort to families.
I have some neonatologists who are a-religious or agnostic or atheist, and in those contexts, I encourage them to not put themselves in an uncomfortable situation. It's okay not to pray. You don't need to say, I'm an atheist. You can just simply say, as Dr. Shukla said, you know, I can get some support. I can get someone else who's better adept at that or who's more comfortable at that. It's okay to be honest. And, you know, if someone really pushed you and tried and maybe offended you and, you know, said, you know, started, well, what's your religious background? You might just simply say, you know, you seem like a person of faith. I'd appreciate that you would just pray for me to give you the best care, and leave it at that.
Okay, thank you. Does any other speaker have anything else that they want to add? Okay, so another question that we got was that one attendee wanted to know more about your personal experiences as patients in the context of religion, and what are some good and bad things that you have experienced as a patient?
I guess can maybe relate something. I mean, I've had experiences where, like I was mentioned before about attending funeral. I also, I don't commonly do that, but this particular patient really, you know, I grew close to the patient and the family. And, you know, when she eventually passed of metastatic breast cancer, you know, I felt that I needed to do this, not necessarily just for a family, but I think it was also for myself. And so I did go to the funeral and met with the family, and you know, it was very nice. They were highly appreciative. I think there was closure from my end too. I think often we, you know, I think we focus so much on the patients, but you know, we are human beings, and we also have our own emotions and our own, you know, coping skills that we need to use. And so I think it's really on a case-by-case basis. I've gone to other ceremonies of people that have passed very selectively. Again, you know, people that I've become close with through families and through some of their interactions with me, and it really does bring a lot of joy in their lives. And so I feel if I can even that slightest amount help them somehow cope with this loss, you know, I'm happy to do that.
Yeah, I'd like to piggyback on Dr. Chaudhary's statement. I've been to many funerals because one of the elements of primary care and family practice, you don't just care for one person, you care for everybody. So, and also the circle of life thing, you know, from Lion King, you end up taking care of the whole family. You never know who you're going to meet when you grow up, because when you get older, because I'm still meeting progeny of families now that have grown up and gotten to know me, and you know, they even gone to med school, and I've helped them get in, and it's very interesting. You never know who you're going to keep meeting as you get older, especially if you provide care for people. So in primary care, I've had the pleasure of knowing an entire family, because I speak, you know, I take care of almost all of them. And so you're not just going to a funeral for one person, it's really to represent everyone in the family. And they really appreciate that, and they never forgot that. So I think we have to keep that in mind, or those of us that are not, you know, we see people over and over and over again. And these people truly are like family to me, grown up with them. They've been in my life longer than some of my own family. So I kind of feel beholden to that, and I've just been part of that's just been part of what I do.
I would add, to that question, specifically about as a patient and how faith has played a role in that. I guess I've been fortunate. I personally haven't gone through, knock on wood, an experience like that. But I will say, what comes very clearly to my mind is about 8 years ago, my younger son, he's fine now, was hit by a car, and it was a terrible thing. Got helicopter trauma to CHOP, and had brain surgery that night, that afternoon. Thankfully, he's all fine. He's in college. But at that moment, as I think back, and as I put myself there as a father, I'm at the hospital where I work every day. Everyone knows me. But now I'm in the opposite side. I'm sitting in the waiting room. My son is in the operating room. One of my colleagues in neurosurgery, two of them are operating on him. My wife is with me, who had seen the accident happen, still has, blood on her shirt, and we're sitting there kind of staring at each other. And at that point, I have to say, even as both of us are, we consider ourselves probably faithful, and we pray regularly, and we're, practicing Hindus, but religion wasn't really on our mind at that moment. When you're in that crucible of that experience, we were just sort of holding on for the next word. What am I going to hear next? What's the doctor going to come out with? I wasn't thinking, oh, well, karmic debt has put us here, and, whatever is to be is to be. It's, predestined, or, let's start praying right now. At that moment, it was just, living that experience. As things calmed down, as we moved to the ICU, as we moved, to the regular floor, then faith came much stronger. And I can tell you that our extended family was in deep, mantras were being said constantly. There were diyas, or, lamps being lit all over at all the temples. And, there was a lot of prayer being sent to us, but we couldn't really process at that moment. And I think, you don't be surprised if you, as spiritual as you are, as religiously competent as you are in that moment, it can all slip by you. But as the shock sort of wears and you kind of get back to on your feet, it came to us, that this is playing out. Now, as we look back, we can say, well, that was a moment, a karmic debt from whatever got burned off, and smooth sailing. Wasn't that a great thing? It's over. Went through it. We suffered. And we've come out. But not everyone does, and we think back to, what if we'd lost him? What would we be saying? Oh, well, it's a karmic debt. Isn't that okay? I don't think we can speak for that. We can't speak for what the universe had in store for why that happened. I find, from my tradition, I find some solace when I see a baby who has made no sins, has not performed a single problem of bad karma, to now be suffering. To know, well, that's we're just here in this moment. We're really, our souls are everlasting. Our bodies are temporary, but we are ageless, timeless. This is just a moment of time. This experience happened. Much better things are ahead. The family that is left behind is suffering. But hopefully even that has cleansed that family and begins a much smoother transition in the future. Will bring them closer to their ultimate destination. So, I mean, that's the best we can do as human beings, as we try to process all of the things that are happening. But I think that's what I would say. Don't be surprised if it's not like, front and center as you're going through this horrible crisis. But it will, in the end, it'll be a substratum. It'll be, sort of this matrix that will carry you through. And I think, in my bias, having faith will provide you that comfort and that sort of matrix, or scaffold to navigate through what you just experienced.
I would just like to comment on my positive experiences of praying with patients. And that takes, spiritual sensitivity. You don't do it in the middle of, crises. It's typically when things are calm and they're you're just giving them updates and they're asking you questions, and you can see anxiety. And as you've gotten to know them, you may know their religious background. And so I will ask them, would you like me to pray, with you? And I'd probably say 99% of my experiences throughout my career of 30 plus years, that's been the response, if you ask it sensitively, genuinely, and in the right moment. And what it does is, whether it's adult patients, or obviously I'm not asking permission to pray with the infant, but there's times where I'm like doing my physical exam and making my observations, and I'm saying, God, Jesus, you are the great physician. Unless you come and give us insight to figure out what's going on, or unless you intervene. So I am quietly praying for my patients sometimes, and many times with the parents, I will pray, because that calms them down, gives them courage, and it creates trust and connection with them. And I'll just give one example where I prayed. There was a mom who I was called in to do a prenatal consult. She was about 28 weeks gestation, and nothing they were doing was stopping her preterm labor. And I found out she was from Haiti. She was, her husband was back in Haiti, couldn't come to visit, and there's nobody around in the States except for one friend who wasn't there. And so as I, gave her did the consult, got the history, sensed that she had some spirituality in her background, and asked her a little bit about it. And I said, would you mind if I just pray for you? And she just lit up and says, oh, I would love it. And so I asked her, can I have permission to put my hand on your baby's belly? And, I told her, with all 5 of my children, every night, I would, pray for my, over my children in the womb. And so she appreciated it. And, many times they just go into labor in spite of her medicines and tocolytics. But this particular time, she didn't deliver. And I went to see her the next morning because I was doing my 24-hour shift. Make a long story short, it wasn't until about 34 weeks because she was in the hospital that whole time, did she deliver. And interestingly, I was able to be at that delivery, and we had an unusual situation. Somehow I also ended up discharging the baby, but she was extremely appreciative, and it really calms them down, decreases their stress. And, and one last little thing is, in medicine, we usually have this phrase, see one, do one, teach one. And I remember in 3rd year medical school, right when I started my internal medicine rotation, I was a brand new Christian, and every day on rounds, this about a 70-year-old woman had a very sharp mind, kept asking the attending, the chief resident, and the rest of the crew, okay, about the medical stuff. I know I'm going to die shortly, and you're just doing this to keep me prolonged, but what's going to happen to me after? And she's talking spiritual. And every day she asks the same question. The social worker, the chaplaincy, no one was able to really help her. And so as I got to know her over those 6 weeks or 8 weeks of internal medicine, I went and asked her her background, asked if I could have the permission to share good news, to give her hope. I shared the gospel. She, prayed to God for forgiveness. She became a Christian, and she was so excited because she was in conflict with her 2 daughters. She was able to resolve that conflict, and shortly thereafter, she did die. So, we need, to give hope. That's a very unusual story, but to just give you an idea that there is a place for spirituality in medicine, because when they lose the hope on this side, they want hope on the other side.
Thank you so much, Dr. Rick, for that transition. We are at the end of our programming here, but if the panelists wanted to say, or the speakers wanted to say some ending remarks.
Well, I just want to thank you for inviting me. I would just, I saw the last question was, what inspiration do you draw from your religion in the field? And I'll just say again, coming back to, we do our duty without any expectation or reward. Don't tie the work that we do to what we might get for it. And another very, very important thing is, the I-ness of it all, right? The ego of it all, that, oh, I am doing this surgery, I am healing, am I not great? Wow, what a great result I got. Because, as you know, like sports or anything else, the next moment you're like, how did that happen? So, separating that, I am the doer, and knowing that, we are the instrument, that we are carrying out our dharma, our duty, to the best of our ability. That's all I think we can do as physicians, as healers. Do your best, but don't be tied to it, and certainly don't think that you are doing anything.
I just want to also thank you all for allowing me to do this. I didn't expect it. It's been a pretty intellectually stimulating. It's really not something you'd expect in medical school. So this is pretty cool that we're doing this. We should do more of this stuff. But what I would say is to just tap on to Dr. Shukla's story, and I think each of us is going to have a personal experience or two or more. And I think when you're with a patient, think about what you would do if that was you. Put yourself in their position. Think about if you had that, if this was your mother, your sister, your brother, your aunt. I do that with almost everybody, and that's how I come to a medical decision. It's a lot easier for me to do that. I'll involve them in a decision making, to a point, whether it's spiritual or not. But I think just because we're all the same, we all have feelings, we're all human like that. I think involving your patient, if it need be spiritually, that's great. But imagine that was you sitting there. What would you do? And I appreciate what Dr. Chaudhary, I've been in that situation many times. When you're a patient, and some of you know that you're rotating with me, I like to use movie metaphors and metaphors of life. There's about 5 or 6 movies that I have never forgotten about doctors and relationships and this topic that have been ingrained in me. And I'll probably push some of you to watch it. Like something called The Doctor, Pay It Forward. A number of very spiritually based movies there are to help you. So that's all I'm gonna say. So thank you again.
Yeah, I'll just make a quick comment. I believe it's much easier to connect with your spirituality of your patients when you're connected with your own spirituality. And so I would encourage all the medical students, whether you're an atheist, an agnostic, or whether you're one of the 5 major religions, it doesn't matter. Just simply pray to God and say, I want to understand this more. I want to know that you are real. Reveal yourself to me. If you're as powerful and almighty as you are, make yourself personal. Make this journey real for me so I can help my patients. And I believe he will answer that prayer.
So the inspiration that I draw from Islam is that hope, I think, this hope that this life and the struggles and the journey, eventually mean more than this journey that we have. And, being a physician and having that white coat, I think it also helps patients feel that there's hope when they come to us. And when they are suffering and they are dealing with issues, because many times we have that 15-minute visit, we don't write a single prescription, we don't do a single procedure, we just talk to the patient and they feel better after they've seen us. And what a tremendous amount of power that we have, but also responsibility that we can do something like that. And it's so unique. And so, I think that really gives me a lot of hope, and I try to carry on that hope and spread it in different ways to the people that I interact with, whether they're patients or just other colleagues or other staff at the hospital. And I just want to finally thank the other panelists. I've learned a lot from all of you, and I agree that this was really a great experience for me and a unique one. And I hope that I've been able to enlighten some people, and I look forward to some of these sessions in the future.
Thank you so much to all of our panelists and speakers. You have had such a deep, meaningful conversation in this session, and you're always welcome back to be in our religion and medicine panel. To all the attendees, thank you for coming to this program during Diversity Week. Tomorrow, we will have the Women in Medicine panel from 6 to 8 p.m. in the NPR, and look out on the group meets for registration. Thank you.
Thank you all. Have a great night.
Thank you. Thank you.
Bye-bye. Good night.
Good night.